My name is Debbie Harvey and I'm the Primary Care Lead at Cheshire Merseyside Cancer Alliance. I'm going to run through the network contract for 21-22, which has a focus on early cancer diagnosis. The background to the DARES is as follows. The NHS long-term plan sets out that by 2028, the proportion of cancers diagnosed at stages 1 and 2 will rise from around 50% to 75%, and critically, this will in turn improve 5-year survival. Achieving this, though, requires a whole systems approach, with a focus on primary care being to improve referral practice for suspected cancer and encouraging participation in the national cancer screening programmes. In the first wave of COVID, we know that 2-week wait referrals dropped significantly. So there has been some recovery in this, but it has not been the case for all tumour pathways, particularly lung and urology. So identifying, diagnosing and treating these missing cohorts is a priority for the coming 12 months. The other area for primary care is that we have a key role in continuing to grow public confidence in the safety and the availability of general practice services, and that includes the availability of face-to-face consultations when required. The other part of the context of the DARES is the crucial role that PCNs play. The first is in coordinating comms across call network practices and secondary care on any local changes to protocols and current practice in the way that 2-week waits might be managed, in line, of course, with national guidance. Where any changes to protocols are agreed, including prioritisation, particularly high-risk patients for more urgent assessment, working with secondary care to ensure those patients receive appropriate safety netting and ensuring that anyone whose condition deteriorates can be urgently escalated for investigation are really important areas. The third part in the PCN role is working with cancer networks, and that's to understand which groups of patients and with which symptoms are most at risk at having missed a cancer diagnosis during the pandemic, and focusing attention on those groups appropriately. The other area is to support the efforts to implement personalised stratified follow-up pathways and support patients to self-manage their care. So this means, where appropriate, that people are not attending unnecessary hospital appointments and are receiving assessment and support by other means. So, for example, a cancer care review by telephone or referring to a social prescriber link worker. The final point that's outlined in the DARES is that diagnostic centre pathways can support the use of community-based or virtual approaches to manage referrals. PCNs, therefore, need to work with alliances in supporting efforts to avoid unnecessary hospital attendances. For example, implementing new proposals for dermatology spot clinics in the community. So we have a number of local system partners, some of whom are outlined here. Some details are awaited but will be uploaded onto the website. The other area is the National PCN Dashboard. So this displays PCN performance in relation to key service indicators and currently includes cervical screening and safety netting. It can be accessed via Insights and on the NHS Viewpoint. It's important to note that in order for safety netting to be uploaded onto the system, that you have to use the specified SNOMED code. So the 3 key service requirements for the coming year are, firstly, reviewing referral practice, secondly, to contribute to national cancer screening, and thirdly, to establish a community of practice. With regards to reviewing referral practice for suspected cancers, including recurrent cancers, there are 4 key components: referral quality, safety netting, signposting, and considering unwarranted variation. So if we look at reviewing referral practice, the DES specifies reviewing the quality against the recommendations of the NICE guidelines and also making use of clinical decision support tools, practice level data, and also, where available, referring to rapid diagnostic centre pathways for people with serious but non-specific symptoms. The next part of referral practice is safety netting, and this requires building on current practice to ensure a robust and consistent approach to monitoring patients who have been referred urgently with suspected cancer or for further investigations to exclude the possibility of cancer. The next point is to ensure that all patients are signposted to or receive information on their referral, including why they're being referred, the importance of attending appointments, and where they can access further support. The next part of reviewing referral practice is to identify and implement specific actions to address unwarranted variation and inequality in cancer outcomes, and this includes access to relevant services. The second part of the DES is looking to contribute to improving local uptake of national cancer screening programmes. So this will involve working with local system partners, including NHS England, Regional Public Health, the Alliance, and so forth, and to agree the contribution of the PCN to local improvement plans. And this should build on any existing actions across the PCN core network practices. This has to include at least one specific action to engage with a group with low participation locally within agreed timescales. And the second point to this is supporting the restoration of the NHS cervical screening programme and looking at opportunities across the network to provide sufficient cervical screening sample taking capacity. The final part of the DES is to establish a community of practice between practice level clinical staff to support the delivery of the requirements. So this is looking at ground level peer-to-peer learning events to look at data and trends and diagnosis across the PCN, including cases where patients presented repeatedly before referral and looking at late diagnoses. It's also about engaging with local system partners, including patient participation groups, secondary care, the Cancer Alliance and Public Health, and also about identifying successful improvement activity undertaken by constituent practices in support of the QOF framework requirements on early diagnosis, and to ensure that successful practice is implemented and developed across the PCN.